Hi, I'm Dr. Randy Martin with the Marcus Heart Valve Center at Piedmont Heart here in Atlanta, and I'm thrilled to be joined by a good friend and colleague, Dr. Mike Picard. Mike is the director of the Echocardiographic Lab at the Mass General Hospital, the MGH, famous institution, and is also professor of medicine at Harvard Medical School. Mike, thanks for joining me.
Oh, pleasure to be here.
You know, you've been president of the American Society of Echo. You've had numerous titles. Mike, you know, we were just chatting about a simulation lab at the MGH where surgeons and others are learning how to do things. Tell me a little bit about that, because it caught my fancy.
So we've got an operating room that's essentially outfitted with lots of gadgets, computers, models, where we can allow trainees and even senior people to simulate, just as you might do in a flight simulator, various procedures and operations. So at the simplest level, we can have medical students, interns, and residents learn how to put in internal jugular catheters and other catheters, or even just draw blood from models, rather than practice on patients the way you and I used to do.
Do one, teach one.
The way you and I used to do it in medical school. Learn how to do gynecologic exam and things like that. More sophisticated things include, actually, our sonographers and cardiology fellows learn how to do echocardiograms, both transesophageal and transthoracic, again on a model, learning where to put the transducer, what the picture will look like if they put the transducer certain ways. And then at the highest level, the invasive procedures like operations and invasive.
So Mike, this is, I mean, obviously it makes a lot of sense. I mean, they've been using this in airlines for a long time to train pilots and check their efficiency. Are you checking the efficiency or the good outcome of whoever is doing whatever they're doing?
Actually, there's a few different points. First off, nowadays, for maintaining your credentials in medicine, you have to demonstrate that you're maintaining your competency.
Right.
And so this is one way where, going through these trainings, you can get certification that you are up to date. The second is that we're able to check where the errors are made during these procedures, right, and both for that specific individual, but for the population of all the trainees in general, change our way we're teaching, or to prevent those types of things. And it's sort of a seal of approval that I think the patients like.
I mean, it makes all the sense in the world. I mean, and this certainly we've lagged behind in medicine to the colleagues in the air industry and airline industry. Mike, I could talk about that because it fascinates me. But let me ask you. As you've had tremendous experience in the field of echocardiography and have certainly been a leader in a lot of areas, where are we with the ability of echo in your hospital in Mass General? How is it seen by the colleagues in surgery and interventional cardiology? I mean, how do they use it? Are they using it just for diagnosis, or are they using it to direct therapies, look at outcomes?
Well, we're actually using it, let's say, in 4 different ways. Okay. As you mentioned, for screening and diagnosis, just to, patient has a murmur or some finding, we want to figure out if it's the heart and what part of the heart. The second is in guiding some of the treatments. In the operating room, we'll do the echocardiograms before the surgery to help the surgeon know exactly where the problem is. So maybe they cut the chest in a little different place, or cut the heart a different way. Or in the catheterization lab or the electrophysiology lab, again, to guide where to put certain devices. The third is a little bit more of a research orientation, where we're studying the physiology of the heart and hoping that our research will guide new therapies. That's a little bit more futuristic.
Right.
And then the last is a quality one, and that we are using echocardiography to make sure that our physicians are doing the right tests at the right time for various conditions. And so we're teaching at an early stage to give good habits to people, but also for some of the more senior people, maybe correcting some of the not so good habits to keep this a cost-efficient process.
So does it continue, let's say, with the surgeons or the interventionalists? I keep coming back to that because we're talking about structural and valve heart disease. Does it continue do they look at echo as sort of their primary imaging tool, or there have been tremendous advances with MR, cardiac magnetic resonance and CT? How do they view it?
It actually depends on the practitioner and the specific disease or indication. So for, I would say, the majority of the conditions, the echocardiogram is the primary tool. Although it's interesting, it's not the fancy bells and whistles. It's some of the pretty basic stuff that we've been doing for maybe 10 years or more. And they are integrating some of the newer measurements and some of the newer pictures. It's certainly, with our new three-dimensional imaging, they like to look at a picture that looks like the structure they're used to looking at. So that helps from a visual qualitative standpoint. But when you get to the quantitative stuff, we're still using some of the measurements we've used a long time, which in a way is good because there's a legacy. In that if the measurement of, let's say, the heart pumping function, the ejection fraction, is 58%, and we've measured it the same way 5 years ago and it was 65%, then we know there's a difference. If you start putting in new types of measurements, you don't know whether it's the yardstick's the same.
Well, in your lab, to your credit, has been, I mean, your facility has been one where you've really emphasized quality and reproducibility of the echo studies. Let me ask you just sort of a global question here. Where do we stand today with the ability of echo to evaluate global and regional left and right ventricular function? We have a lot of interesting things about valvular imaging and all that stuff, but it really is how the heart is functioning as a pump. Is echo the way to do that?
I think from a practical standpoint, for a day-to-day basis, it's the way to do it. There are some of the other tools like CT, MRI, and a few others, even PET scanning, where we can probably get a finer, higher resolution, maybe a little more accurate measurement, but it's just not practical on a day-to-day basis in terms of throughput. In our hospital, we have to image at least 100 or more patients a day in our echo lab. You just can't do that with those other technologies. So we are the go-to procedure. I think to delve a little bit more into your question, for global function of the left ventricle, I think we've got some pretty good measurements. For regional function,
ejection fraction?
It's still ejection fraction. That's the currency that all physicians use, whether you're a family doctor, a pediatrician, or an advanced cardiologist. That ejection fraction has stood the test of time. Now, yes, it's got certain limitations, but it works. Now, at the same time, we've added new measurements like strain, global strain, and a few others, which I think make that measurement of EF a little more accurate. So over time, we'll probably integrate those more. But I think most of the physicians still go back to that tried and true ejection fraction.
Right ventricle?
So the RV, I was going to say, up until recently, it's really been an Achilles heel for echocardiography. Our imaging technology has gotten better. The transducers are now got better image resolution, so we can see the RV better. And I think with 3D, that's a place where you can't do it in 2D. The structure of the RV, you can't take one two-dimensional plane and see all aspects of the RV. You really do need to look at the three-dimensional shape and volume of the RV. So this is where 3D is really starting to take off. It's still hard because of the imaging of the RV. It's under the breastbone, and it's harder to see. But we're getting there, and I think in the next few years you will see measurement of RV instead of being a qualitative measure, it'll be a quantitative measure. And in fact, in the next round of guidelines from the American Society of Echocardiography, we have detailed discussion about what is the normal value of the right ventricular ejection fraction.
That's great. Well, listen, Mike, you've done a tremendous job in your own environment up at the Mass General and also with Echo in general, and I certainly appreciate it. You've educated us today about simulation, so we now can we can come learn at the
Remember that game Operation? Well, it's just so another level of that.
We can do that. You've told us a little bit about how Echo's used, and then given us a look at the practical and the future of how we evaluate LV function. Thanks very much for joining us. It was fabulous, and thank you for watching. We hope that you'll join us again.